Mr. Chairman. I'd like to thank all the witnesses for testifying today, but I'd especially like to welcome Dr. Champion, who's here from Grand Rapids, Michigan, in my district, and from Calvin College, which is my wife's alma mater.
You're married well.
Most of my friends went to Calvin College as well. So, Dr. Champion, can you give us an example of how you personally make decisions about the student health care plans at Calvin College and how the mandate will affect your current plan?
Yes. So when I came to Calvin College this summer, I analyzed the student plan that was there. I learned that we charge $15 for every visit. We have phenomenal state-of-the-art physicians doing evidence-based care, yet Calvin chooses to subsidize their care by limiting the cost, even though we have a student plan that we do bill at 100% when they come in for preventative care. This is because we really emphasize the value of being able to instill and educate and train. When I analyzed the current plan, it showed that if she needed to come in for instance, a sexually transmitted disease evaluation, we had to charge her $10 for a gyne exam, $5 for a wet mount, and pretty soon the conversation for an underinsured student who didn't choose our plan would end up needing to be taken about the money relationship to the cost of care. So I redirected that fee in the next design plan to incorporate all of that in and redirect the visit toward the clinician's experienced guided evidence and not a discussion about cost. So by changing the plan in those very specific ways, I'm able to be a good steward of the limited plan we can offer them. When I learned that we have to add abortive agents and expand the coverage to include surgical sterilization, I'm aware that it substantially raises the premium because it does raise the risk, even if a 20 or 21-year-old student never requests a tubal ligation or vasectomy, because we have to add it into our plan. So there are financial reasons and for me to be a good steward of the plan, but more importantly, there are severe contradictions to my personal religious beliefs by adding Ella and Plan B into the plan.
And you're the only medical doctor on the panel, so could you elaborate on why you're opposed to having birth control and abortifacients listed as preventative services?
Right. Well, thank you for asking that, because this is really important to me. Preventative care defined by physicians has to do with anticipating future care by analyzing their past history. So you're asked your social history, your medical history, what age you are. We use your age to determine what your risk is. So a 50-year-old's risk for heart disease or colon cancer will help them determine which preventative care screening they need. When it comes to pregnancy, since it's not a disease, we are now treating a concern for the patient, which we actually move into a visit called diagnostic care. So the diagnosis is contraception counseling. We often will do it at her physical as a courtesy to her because she's so healthy, we don't want to make her come back, but it is actually not a preventative care service. Outside of that, Plan B and Ella are not preventative at all because they are actually a result of behavior where she is purposefully taking the medication to limit her risk for sustaining a pregnancy that may have started a day or 5 before taking the pill. Furthermore, when you talk about preventative care in a young woman, the U.S. federal government did give us new recommendations in December 2010. They did it under the CDC. And they asked physicians to step outside of whatever their Christian or other values are and to start speaking to patients about preventative care when it comes to STDs. And they've required or strongly recommended physicians to now ask patients to limit the number of lifetime partners and delay the onset of intimacy. Those guidelines from the federal government are well within preventative care measures, and I'm happy to abide by them because they do follow my principles, but they're also scientifically based and show that you can minimize STDs by giving this recommendation preventatively.
Does the President's so-called compromise make the mandate any less restrictive on your ability to freely exercise your religious and conscientious beliefs?
When the President spoke on Friday, I had a glimmer of hope that there was going to be an accommodation that perhaps broadened his definition. But he really doesn't have the right to decide the definition of when it is against my conscience. But what turned out to be in the written statement was no different than what he had presented us on August 1st of last year.
Thanks.